Okay, so we're back with aminoglycosides now. Again, just a quick review. Hopefully this will be helpful. So how do we dose aminoglycosides? There's a couple different ways. Conventional and or traditional. We use those words interchangeably. And then there's the extended interval or high dose. So we use conventional dosing when we're doing synergy, as in endocarditis. If we're going to have a patient that's going to be expected to be on it for a long duration of time, or if their renal function is not stable. If they have a urinary tract infection, we can also use traditional dosing. The extended interval or high dose aminoglycosides we use for people with stable kidney function. It is not used for synergy, usually for a shorter duration and most often for pseudomonal infections. So just remember, when we dose aminoglycosides, it needs to be in intervals or multiples of 10 milligrams, okay? And the interval will be Q8, Q12, Q18, 24, etc. So we'll talk about conventional dosing first. This is the chart you need to know, and we'll give you, if you're expected to know what the peak and trough is, we'll let you know. But for synergy, we're looking for troughs, lower trough levels, and peak levels. So the peak would be 3 to 5, and the trough would be less than 1 to 2, and that's always going to be the case with gentamicin and tobramycin. Even with extended interval, we want that random level or trough to be undetectable, okay? So it's going to be less than 1. So again, here's your desired peaks and troughs you can refer back to. So how do we do this? We look at what is the plan for dosing aminoglycosides. We estimate a dose first based on population parameters. So again, population parameters are what we know based on clinical trials and studies. And then we're going to give the dose. We'll check a peak and a trough when it's appropriate, and then we can double back and make sure that our levels and that our estimated dose was appropriate. So first we determine the dosing weight, okay? And there's, Dr. Preston came up with this. We love calculating kinetics very happily in May to help you remember these steps. So first things first, dosing weight, and then we'll look at the loading dose, the creatinine clearance, the elimination rate, the volume of distribution, half-life, dosing interval, and then we'll come up with a maintenance dose. So you have to know this slide, okay? Your dosing weight for aminoglycosides is always going to be ideal body weight unless your patient is obese. And we determine that they're obese if they're 25% above their ideal body weight, okay? So always use ideal body weight for dosing aminoglycosides unless they're obese, or if their total body weight is less than their ideal body weight, okay? And then you would use the total body weight. So total body weight is actual body weight. We configure the adjusted body weight for those obese patients with this formula here. It's basically taking the difference between total body weight and ideal body weight, multiply that by 0.4 or 40%, and then add it back to the ideal body weight, okay? And again, we consider those patients obese if they're more than 125% of their body weight, ideal body weight, excuse me. So how do you know that? If you divide their total weight by their total body weight by their ideal body weight, if it's more than 1.25, then they're more than 25% overweight. And here again is your formula for ideal body weight. You have to know this formula. Okay, so make sure you understand this slide. How do we determine a loading dose? So again, we're talking about conventional dosing. We use that previously determined dosing weight in multiples of 10. If it's a mild infection, and we'll tell you if it's mild or moderate to severe. A mild infection, we're going to do a load of 1.7 milligrams per kilogram. For gentamicin and tobramycin, if we're using amikacin, it's 8. And then we'll go up to 2 for a moderate to a severe infection. We do a loading dose to try to get that level up quicker, so we don't have to wait for 4 half-lives before we're therapeutic. Okay, so we use a load to get the dose, or to get that plasma concentration up to an acceptable level a little bit higher. Okay. How do you calculate creatinine clearance? You guys should know this by now, and I know you do. I'm sure you do. But here again is the formula. So always remember, follows the same rules as aminoglycosides. So we use ideal body weight for creatinine clearance unless they're obese, which again is 125% of their ideal body weight, or if their ideal body weight is less than their actual weight, okay? So serum creatinine, we're going to round up to 1 if your patient's over 65 and their serum creatinine is less than 1. And that is because serum creatinine is a measure of lean muscle mass, right? So that your lean muscle is what produces creatinine. And then we're going to put a cap on it of about 120, and you'll find that to be a little bit different from place to place, but that's a good starting point. Okay. How do we calculate creatinine or elimination rate? So for aminoglycosides, this first step is based on population parameters. Okay, so this is a formula that we've gathered from years and years of study. Okay, it's 0.00293 times the creatinine clearance, and then you add 0.014 to that. This is an estimation. Okay, so this is our first estimation of elimination rate. Okay, to calculate the volume of distribution, for aminoglycosides, we use 0.26 liters per kilogram, and we use the dosing weight, which should ideally be the ideal body weight, right? So this, again, is based on population parameters. This will vary from patient to patient, but this is your starting point, okay? So volume distribution for aminoglycosides is 0.26 liters per kilogram, and then with, you can calculate the half-life based on that elimination rate that we did just a minute ago. So, I've enlarged my screen. Next step is to calculate the dosing interval. And the easiest way to do that, you can use this big fancy formula up here and plug in your desired peak and trough. So this is your desired peak, and the next one is your desired trough, divided by the KE. Or you can simply multiply your half-life by 3 to 3.5. And that will give you an estimated dosing interval. Okay, that's the easiest way to do it. Our next step is to calculate the maintenance dose. And the maintenance dose is going to be that desired peak concentration times the volume and distribution. Okay, so just whatever you want your peak concentration to be from this chart. So if you're treating bacteremia, you're going to want a peak concentration of around 6 to 8 times the volume of distribution. Okay, and remember your dose is going to be in multiples of 10. So now what? We've got our dose. We're going to give our dose, and then we'll measure a trough level prior to that third or fourth dose, 30 minutes before the dose. Okay, we measure a peak concentration after the third or fourth dose, 30 minutes after the end of the infusion. So if the infusion starts at 5 o'clock and it's a 30-minute infusion, we're going to draw that peak at 6 p.m. Okay, so that's 30. It'll take 5 p.m. to 5:30 to infuse the dose. 30 minutes after the dose, we draw the peak. And based on those levels, you can go back and calculate your patient-specific KE and all the parameters that we've just used population kinetics to do. So the first thing we'll do is plug it in. We'll plug in what we got for a peak and a trough into this formula, and we'll get the KE. So we've got tau, which is your capital T, that's your dosing interval. The T prime is the time of the infusion, normally 30 minutes or an hour, depending on your hospital. T1 is going to be the time from the end of the infusion to the peak, hopefully half an hour, that's what it should be, and time from the trough to the start of the infusion. So that should also be half an hour. They should be very close to that. Based on that new KE, you can plug that formula back in and find out what your patient-specific half-life is. So this is not population parameters. Both of these now become, your patient owns these parameters now. And then you can determine the new volume and distribution, where tau, again, is the dosing interval and T prime is the time of the infusion. So you plug that in to get your volume and distribution. Once you get your volume and distribution, again, we're going to look at a new dosing interval. So based on our new specific KE, you can use this formula, or you can take that tau and multiply the half-life times 3 to 3.5, and that'll give you your new dosing interval. To get the new maintenance dose, we use the volume of distribution that we just calculated, okay, and we use our desired peak times that volume of distribution, and that will give you the new dose, okay? And remember that, the peak level is based on indication, so it depends on what kind of disease we're treating, okay? And then if you want to, you can use these fancy formulas, plug it back in to make sure that when you plug in your patient-specific parameters, that it's going to give you that C peak, that peak concentration that you want. And then it'll give you the peak trough, or the trough that you desire. So you can use this formula if you want to double check to make sure that things look the way that they should. Or you can draw another peak and trough, which is what we typically do. So how do we monitor aminoglycosides? Once we get to that appropriate dose, we're going to monitor troughs and peaks depending on, sometimes we'll use peaks depending on the indication, every 4 to 7 days. You want to make sure you're looking at their creatinine clearance at least every 3 days. If you start to see that serum creatinine rise and the creatinine clearance decrease, we need to check levels to make sure that they are clearing the aminoglycosides. Okay? So extended interval, also known as once daily or high dose, we use this to maximize that concentration-dependent bactericidal activity. So we want to get those peaks up as high as we can so we kill that bacteria, and then we want that trough level to come down below undetectable because we have that post-antibiotic effect with aminoglycoside. So even when that level drops off below detectable, it's still going to be working because of that post-antibiotic effect. Okay, so the thought process is that this is going to help decrease resistance, it's going to maximize that concentration, and it's going to decrease toxicity because we'll have a period there where there is no detectable amount of drug. Okay, so in order to use extended interval, we need good kidneys, which means a creatinine clearance between 40 and 60. Exclusion would be bad kidneys, burn patients, cystic fibrosis, if they're pregnant, if there's anything that's going to change pharmacokinetic parameters, or if we're using it for synergy. So we follow the same steps we used before, okay, until we get down to where we're checking levels. So we're going to calculate that. We're going to calculate the dosing weight, the creatinine clearance, the dose, and the dosing interval. And then we're going to check 2 random plasma concentrations to calculate that patient-specific KE, and then calculate the true peak and trough, okay? So your dose here for a mild infection, we're going to use 3 to 5 for a mild infection, milligrams per kilogram, or 6 to 7 for more severe. And then you'll use your creatinine clearance to determine what your initial dosing interval is. You check 2 random plasma concentrations to calculate that patient-specific KE using the same formulas we did before, and then you can back calculate to find the true peak and trough and adjust based on what you find. Okay, so if we check 2 random levels, we're going to plug in random 1 and random 2, and this T is going to be the difference in time between these 2 random levels. Okay, so if that first random level was done at 10 a.m. and this second random level was done at 12, this T would be 2. So that's going to be the difference between the 2 levels, okay? And again, we're working on the slope of a straight line. Use this formula to plug it in. So if you have one, if you get this level, you can notice there's not a negative here. This is a positive because we're taking a trough level and we're taking the first level we draw, but we're backtracking back up that line here to get the true peak. And when we go downstream that line to get the true trough, we're going to use a negative here. Okay, so this will help you use this formula to determine what the true peak and trough are. Okay. If they're appropriate, go ahead and schedule the dose. If not, then we need to do a little bit more work. So once we get that appropriate dose achieved, we're going to monitor those levels again every 4 to 7 days. If we're using nomograms, we need a dosing weight and we need to calculate the dose, and we're going to check 1 level. Okay, so these are nomogram specific doses. So there's a Hartford nomogram that's going to use this 7 milligrams per kilogram dosing. So we'll give them 1 dose of 7 milligrams per kilogram, and then we're going to draw a random level sometime on this axis. So at 9 hours, we'll draw a random level, or it could be 10, and we're going to plot whatever that random level is, and it's going to tell us whether we're using Q24, Q36, or Q48. If it's a lower dose that we're using, we're going to use the consensus nomogram, and it's 5 milligrams per kilogram. These are nomogram specific doses, so you have to make sure you know which one you're using. It works exactly the same way. And then we have another nomogram for amikacin that can be used. Okay, so you order that random level somewhere on this axis, usually around 10 hours. You plot it, and that will determine what your interval is. Okay? All right, man, that was a quick review. Finished just on time.